You know, when you walk into a doctor's office with a problem, there is this deeply ingrained expectation of like absolute engineering level precision.
Right, you expect a totally clear answer.
Exactly. You fall, you break your wrist. The x-ray reveals this jagged white line across the bone, and the doctor just points at the screen and says, there is the problem.
Broken or not broken, it's a clean binary.
Yeah, we love things that can be seen and categorized and immediately fixed. But the moment you step outside of orthopedics and into the world of neurology,
Oh yeah, that is a whole different ballgame.
it really is. Specifically with nerve damage and pain processing, that x-ray machine becomes entirely useless.
Yeah.
You are suddenly navigating this landscape that is incredibly murky, where the physical damage might be totally invisible, but the agony is just off the charts.
The clinical texts actually refer to these kinds of conditions as functional or neuropathic disorders, but, diagnostic muddy waters is a much more accurate description of the patient experience.
Muddy waters is putting it mildly.
Right. I mean, the gap between what a patient feels and what a standard scan can actually prove is often just massive.
Well, welcome to today's deep dive. It is Wednesday, July 22, 2026, and our mission today is to essentially wade right into those muddy waters.
Bring your boots.
Right. We have this fascinating stack of medical texts, anatomical guides, and clinical case studies in front of us, and we are unpacking a highly specific, very complex, and honestly brutally misunderstood medical phenomenon from these sources.
And it's a very specific nerve we are looking at today.
Yes, we are exploring the exact role of the genitofemoral nerve in transmitting superficial burning sensations along the labia majora during initial touch.
Which is such a specific and intense reaction.
It is. I want you, listening right now, to just imagine a scenario where a gentle, completely harmless touch, like the brush of your own clothing or even just a light breeze, feels like a severe, blistering burn.
It's hard to even wrap your head around.
It really is. Why does the body suddenly betray its own sensory system this way? It is this fascinating collision of anatomy, physical nerve damage, and literal glitches in the central nervous system software.
And reading through these sources, the most heartbreaking takeaway is that people suffering from this specific pelvic pain are routinely misdiagnosed or just entirely dismissed.
Dismissed as it being all in their head, which we will see is absolutely false. So we're going to unpack the biological mechanics at play here piece by piece so you can truly understand what is happening.
Yeah, to figure out why a gentle touch translates into a severe burn, we have to start with the hardware. We need to trace this specific biological wire from its power source all the way down to its endpoint in the female body.
Okay, let's trace the wire.
So the genitofemoral nerve has a fascinating and frankly, somewhat precarious journey. It originates really high up in the lumbar plexus. Specifically, it branches off from the L1 and L2 spinal roots.
Wait, L1 and L2, so we are talking about the lower back, essentially upper abdominal area, which is nowhere near the pelvis yet.
Right, exactly. And from that really high origin point, it descends through the abdomen. But instead of taking a safe, protected route alongside the core muscles, it actually pierces directly through the psoas major muscle.
Okay, let's think about that for a second, because the psoas is your primary hip flexor, right?
It is, yeah.
Every single time you lift your knee to walk, climb stairs, or even just sit up in bed, that massive core muscle is contracting and stretching. Having a delicate nerve cable drilled straight through the middle of a highly active muscle seems like a massive anatomical design flaw.
Oh, it absolutely sets the stage for vulnerability, which we will see in a moment.
Yeah.
But once the nerve emerges on the front surface of that constantly moving psoas muscle, it continues downward and splits into two distinct divisions.
And those are?
The femoral branch and the genital branch.
Got it. And since the focus of our deep dive is the burning sensation along the labia majora, we are tracking that genital branch.
We are. So in females, this genital branch enters the deep inguinal ring and travels through the inguinal canal, which is a very narrow passageway in the lower abdominal wall.
It physically travels alongside the round ligament of the uterus?
Right. And finally, its journey terminates at the mons pubis and the labia majora. That is where it essentially embeds itself in the tissue to provide sensory innervation.
So it's like the designated security camera for that specific region of skin.
That is a great way to put it, yeah.
But, reading through the anatomical studies in our stack, that standard textbook map is not actually reality for a huge portion of the population.
No, not at all.
The sources highlight that anatomical variations are incredibly common.
Yeah, the cadaver studies in these sources are actually quite startling for anyone who assumes human anatomy is totally standardized.
Which most of us do, right? You assume we all have the exact same wiring.
Exactly. But in about 43.7% of women, this specific genital branch is either completely absent as a distinct, separate wire, or it is heavily intertwined and bundled with a neighboring nerve called the ilioinguinal nerve.
Wait, almost half.
Very half.
That means for nearly half of the women walking around today, the standard anatomical textbook blueprint that a surgeon might be referencing doesn't even match their actual bodies. The wiring is completely custom.
It is.
I mean, I imagine that is terrifying if you are the patient on the operating table, knowing the doctor's map might be entirely wrong for your specific anatomy.
And that variation is the primary reason this specific neuralgia is an absolute nightmare for clinicians to diagnose.
Because they literally don't know exactly where the wire is.
Right. If the nerve isn't where it's supposed to be, a surgeon might inadvertently clip it, or the pain specialist might miss it entirely when trying to treat it.
Wow.
But regardless of whether it's a distinct branch or bundled with its neighbor, that sensory connection from the L1 and L2 spinal roots down to the labia majora is established. So that is our hardware.
Okay, so the hardware is in place. Now we need to look at what happens when that specific wire gets compromised. And the clinical sources refer to this as genitofemoral neuralgia.
Yeah, neuralgia just being the medical term for pain spreading along the path of a nerve.
Right. And because we just traced that precarious path originating in the lower back, piercing through the active psoas muscle and snaking through the narrow inguinal canal, you can easily see why this nerve is incredibly susceptible to mechanical damage.
The wire basically gets pinched, stretched, or crushed.
And the sources list a few really common culprits for that damage.
What do they find?
Well, inguinal hernia repairs are a huge one, largely because of the mesh used to repair the tissue, which can physically trap or inflame the nerve.
Oh, that makes sense.
Yeah, and pelvic surgeries, blunt trauma to the abdomen, or even something as mundane as chronically wearing excessively tight clothing over the groin area can compress it.
Wow, just tight clothing.
Yeah, and once that nerve is mechanically damaged or compressed, the patient experiences that genitofemoral neuralgia.
Which manifests as a constant or sometimes intermittent burning pain, or tingling, or even a deep numbness in the groin and the labia majora.
And because of the nerve's path through the hip flexor region, physical movement directly impacts the pain level.
Right. The texts note that walking, bicycling, or just extending the hip backward causes a massive spike in pain.
So much so that patients actually adopt what clinicians call a novice skier's position.
A novice skier's position.
Yeah, standing slightly bent forward at the waist with their hips flexed.
Oh, I see. By bending forward, the patient is physically creating slack in the nerve cable.
Exactly.
They're removing the mechanical traction that is stretching the damaged area and causing it to misfire.
Okay, but hang on. I need to stop us here because there is a massive logical gap I am struggling with based on what we've covered.
Okay, what's the gap?
If the surgeon nicked the nerve way up by the psoas muscle during a hernia repair, or if the compression is happening in the abdominal wall, why on earth is the patient feeling the burning fire all the way down in the labia majora?
Right, that is
Shouldn't their upper abdomen be what hurts?
the perfect question to ask, actually. And it gets to the absolute core of how the brain maps the physical body.
Okay, lay on me.
Your brain doesn't actually possess sensors along the middle of a nerve cable. It only monitors the data coming from the endpoints.
Oh, interesting.
This is the exact mechanism behind referred pain.
So if we go back to our security system analogy, the central alarm panel in your brain says front door breach, even if the wire was actually chewed by a mouse down in the basement.
That is a flawless way to visualize it, yes. The genitofemoral nerve is exclusively assigned to monitor the cutaneous or skin sensation of the labia majora.
Okay.
So when the nerve is crushed or irritated higher up in the abdomen, it sends a frantic distress signal. The brain receives that signal, looks at its internal map, and incorrectly projects the sensation of pain to the nerve's terminal destination.
Wow.
The brain essentially hallucinates that the labia majora is under attack, even though the skin down there is perfectly healthy.
Okay, that makes so much sense. The mechanical pinch causes the baseline aching, the tingling, the constant distress signal.
Right.
But that still doesn't explain the central mystery of our deep dive today. A pinched wire explains aching pain. It does not explain why a completely harmless initial touch, like putting on underwear, suddenly triggers a sensation of being burned with a hot iron.
It's a huge leap.
It is.
Yeah.
What shifts in the body to turn a light touch into a severe burn?
Well, To bridge that gap, we have to look beyond the nerve itself and examine how the central nervous system, the spinal cord, and the brain adapts to chronic distress signals.
So we're moving from the hardware to the software.
Exactly. We're looking at the programming.
Yeah.
The clinical literature defines two entirely different pain phenomena here, hyperalgesia and allodynia.
Let's break those down because they sound similar but operate very differently.
They do.
Hyperalgesia is essentially an exaggerated response to something that should hurt. Like if I pinch your arm, you expect a mild ache. But with hyperalgesia, that same mild pinch feels like you are being stabbed with a knife. The volume of the pain is dialed up completely out of proportion to the stimulus.
While allodynia is fundamentally different, allodynia is a severely painful response to a non-noxious stimulus.
Meaning something that shouldn't cause pain at all.
Exactly. The light brush of a cotton swab, the friction of walking, or a gentle touch, it is registered by the brain as agonizing pain.
So the receptors aren't just firing more easily.
No, they are completely misinterpreting the type of data they are receiving.
It's like a thermostat that breaks and suddenly starts reading a comfortable 70-degree room as boiling hot. The data entering the system is normal, but the processor is spitting out a catastrophic error message.
And the medical term for that broken thermostat is central sensitization.
Central sensitization.
Here's the biological mechanism. When that genitofemoral nerve is injured, it doesn't just send one pain signal. It sends a continuous, relentless barrage of distress signals up to the spinal cord.
Just nonstop.
Nonstop. Specifically, these signals bombard the dorsal horn neurons, which are the biological relay stations in the spine that pass messages to the brain.
So they just get completely overwhelmed by the constant noise.
They do. And the dorsal horn neurons physically adapt to that bombardment.
They change.
Yes, they undergo a structural change, becoming intensely hypersensitized. This drops the nociceptor, meaning the pain receptor thresholds, straight to the floor.
So the body is essentially having a massive systemic overreaction. And we have fast-acting nerve fibers, right? The sources call them A-delta fibers, which are myelinated.
Yes, myelinated fiber.
They have this biological insulation that allows signals to travel incredibly fast, which is why they usually transmit sharp, immediate pain, like if you touch a hot stove, compared to the slower C fibers that transmit dull, throbbing aches.
Exactly right. And because the dorsal horn and the spinal cord is so sensitized now, those fast-acting A-delta fibers begin transmitting amplified signals at the slightest provocation.
Just a hair trigger.
A light touch activates them. The sensitized spinal cord aggressively amplifies the signal, and it hits the brain as a fast, sharp, severe burning sensation.
And what absolutely blew my mind reading these sources is that doctors don't just have to take a patient's word for this. They don't have to guess. They can actually measure this biological panic using electromyography or EMG studies.
Yeah, the EMG data provides undeniable, tangible proof that this is a physical pathology. It's not subjective.
Wait.
If you take a healthy female without this condition, the baseline resting electrical activity of the vulval muscles is about 1 to 2 microvolts.
So the tissue is quiet, it is completely relaxed.
All right.
But the sources show that in women with provoked pain, meaning the allodynia triggered by touch, that baseline resting tension jumps up to 2.5 microvolts.
Which is a significant increase.
And in women with unprovoked constant burning, it skyrockets to between 3 and 5 microvolts.
It's massive.
If the resting tension is tripling, that means the muscle tissue is never actually resting. It is essentially sprinting a marathon while the patient is just trying to sit on the couch.
The tissue is practically vibrating with electrical tension. The entire local nervous system is locked in a state of hyperarousal, just buzzing with excess energy, literally waiting for a single cotton thread to brush against it so it can tip over the edge into sheer agony.
That sounds biologically exhausting for the patient.
It is completely exhausting.
And this central sensitization is happening up in the spinal cord, but the burning is intensely localized at the labia majora. And our sources point out that this specific region of the body is a wildly complex biological environment. It's not just standard skin.
Not at all. The vulva, including the labia majora, possesses a remarkably high density of epidermal nerve endings compared to non-genital skin. It is just densely packed with sensors in the dermis and subcutaneous layers.
And worse than that, the body's reaction to chronic pain actually makes the density worse, right?
Oh, yeah.
When they take biopsies of women suffering from this specific localized burning, the tissue shows a massive proliferation of nerve fibers.
The body literally grows more nerves.
Right. The body thinks the area is under attack, so it actually grows more pain-sensing wires to monitor the fake threat.
The body is trying to protect itself, but it's basically pouring gasoline on the fire. And alongside that new nerve growth, biopsies reveal a heavy concentration of mast cells.
Which are the immune cells.
Right, mast cells are key players in the immune system, responsible for releasing histamine and triggering inflammation.
Oh, great.
So you have localized chronic inflammation surrounding an abnormally high number of nerve endings, all feeding back into a spinal cord that has entirely lost its ability to regulate pain signals.
It's a perfect storm. The sources also introduce a concept called crosstalk, which seems to complicate this even further.
It really does.
They mention that up to 15% of these nerve fibers combine somatic activity with parasympathetic motor activity.
Let's translate that.
Right, to translate that out of textbook jargon. Somatic activity is your conscious ability to feel touch and pain, while parasympathetic activity handles automatic, background functions like blood flow and glandular responses.
And when you have all of those densely packed, hyper-aroused nerves firing constantly, the insulation between them essentially fails.
Like the old landline telephone wires that used to run across cities.
Yeah, perfect analogy.
If the cables were packed too tightly and the signal was too strong, you could pick up your phone and faintly hear your neighbor's conversation bleeding into your headset.
That is exactly what happens on a cellular level. The relentless somatic pain signals literally bleed over into the parasympathetic nerves. This triggers what clinicians call neurogenic inflammation.
So it spreads.
Exactly. The inflammation and pain don't just stay in the labia majora. The crosstalk causes the distress to spread to neighboring organs that share that same pelvic real estate.
Wow.
So the patient might suddenly develop severe bladder pain, bowel issues, or widespread pelvic aching, all radiating from that single pinched genitofemoral wire.
Which brings us to the ultimate clinical challenge, really. If a patient is experiencing localized burning, but the area is inflamed with mast cells, extra nerve fibers, and crosstalk that makes their bladder hurt, how does a doctor actually isolate the genitofemoral nerve as the culprit?
It's extremely difficult.
Especially if the patient is part of that 43.7% whose wiring doesn't even match the textbook. Standard oral medications like gabapentin or neuropathic pain blockers don't seem to work, according to the text.
No, oral medications frequently fail because they act as systemic blankets. They depress the entire nervous system, which causes side effects like brain fog and severe fatigue without actually addressing the localized structural glitch.
So what do?
To definitively isolate the genitofemoral nerve, specialists utilize targeted nerve blocks. Using ultrasound guidance to navigate the unique anatomy of the patient, a doctor injects a local anesthetic precisely around the genitofemoral nerve, high up in its pathway.
It's an elegant solution because it acts as both a diagnostic tool and an immediate therapy. If the doctor injects the anesthetic and the patient's severe burning pain upon touch instantly vanishes, they have their definitive answer. They found the right wire.
Yes. It perfectly isolates the hardware problem.
Yeah.
But of course, the limitation is that the anesthetic wears off and the pain often returns.
All right, it's temporary.
So for long-term management, advanced clinical sources look toward interventions like pulsed radiofrequency ablation.
That sounds intense.
It uses targeted electrical currents to essentially stun the nerve, interrupting the pain signals for months at a time. They also utilize EMG biofeedback, which involves hooking monitors up to the patient so they can visually see that 5 microvolt tension on a screen.
Oh, so they can see their own nervous system firing.
Yes, and use cognitive techniques to consciously train the muscle to relax back down to 1 or 2 microvolts.
That is fascinating. But I have to say, the most fascinating intervention in our stack of sources is a case study involving a treatment usually reserved for cosmetic wrinkle.
Oh, Botox.
Botox. The case study focuses on a 78-year-old woman whose situation was just dire. She had suffered multiple severe pelvic fractures in 2013. Years later, she developed debilitating, constant burning pain in her labia majora.
That sounds awful.
On the clinical pain scale, she rated it a 9 out of 10. The allodynia was so severe and the pain spiked so high when she extended her hip that she was completely unable to walk.
She had exhausted all oral medications, and she understandably refused further invasive surgery. I mean, at 78, with past trauma.
Absolutely. But her pain specialist tried an off-label approach. They administered subcutaneous injections of botulinum toxin type A Bonte directly along the territory of the genitofemoral nerve.
And it worked.
She found profound, successful pain relief. But this is where I have to pause and look at the underlying mechanics.
Okay, let's look.
Botox works by temporarily paralyzing muscle tissue and blocking neurotransmitters, right? But if we are talking about central sensitization, the spinal cord fundamentally rewiring itself to misinterpret touch, Are we just temporarily unplugging the siren with Botox, or does this treatment actually help fix the broken software in the spine?
It is actually about forcefully breaking a pathological feedback loop.
Breaking the loop, okay.
By unplugging the siren with Botox or a nerve block, you stop that relentless barrage of distress signals from bombarding the dorsal horn neurons. You enforce silence.
Wow. Enforced silence.
Yeah, and if you can keep that nerve quiet for a sustained period, the central nervous system finally has a chance to downregulate.
Like rebooting a frozen computer.
Exactly like that. The structural changes in the spinal cord can slowly reverse. The nociceptor thresholds rise back to a normal, healthy level, and that hyper-aroused vibrating tension dissipates. It isn't just masking the pain, it is providing the biological silence necessary for the central nervous system to reboot.
It literally gives the body permission to stand down from red alert. Let's take a step back and look at the whole picture we've painted today. We started high in the lumbar spine, tracing the genitofemoral nerve as it pierces through the active psoas muscle, snakes through the abdomen, and sends its customized genital branch to wire the labia majora.
And we answered the core biological mystery of our deep dive today.
We did.
A harmless initial touch is translated into a severe, superficial burning sensation because mechanical damage to that nerve, whether from a hernia mesh, trauma, or tight clothing, triggers central sensitization.
The dorsal horn gets overwhelmed, the spinal cord's pain thresholds drop to the floor, and the fast-acting A-delta fibers start translating the gentle friction of clothing into a blistering burn.
It's an incredible chain reaction.
It is.
Yeah.
And if you are listening to this right now and you have experienced this kind of invisible, inexplicable pelvic pain, I really hope you take away the singular fact. The high-voltage EMG readings, the physical proliferation of nerve fibers, the mast cell inflammation, all of this data proves that your pain is a tangible, measurable, neurological rewiring.
Yeah.
It is a physical reality. It is not, and never was, a psychological manifestation.
The pathology is in the wires in the dorsal horn, not in the patient's head, period.
Period.
And understanding that mechanism leaves us with a truly fascinating frontier to consider.
Oh, where are we going?
Well, we spent this deep dive exploring how the central nervous system adapts to chronic distress. We've seen how the spinal cord, through neuroplasticity, essentially learns to misinterpret light touch as severe burning pain.
Right.
It memorizes a pathological state.
The nervous system learns the absolute wrong lesson.
But neuroplasticity is a two-way street.
Oh, I see where you're going with this.
Right. If the cellular architecture of the spinal cord has the plasticity to learn this severe pain state, could future therapies bypass physical interventions entirely?
Wow.
Could we eventually rely on advanced neuromodulation, targeted cognitive sensory retraining, or even immersive virtual reality therapies to teach the spinal cord to unlearn this pain?
Teaching the spinal cord to wipe its own cellular memory of pain, without drugs, without scalpels, and without needles.
Exactly, just rewiring the software.
That is an incredible thought to end on. We started today looking at a diagnostic landscape that was impossibly murky. But knowing that this burning sensation isn't a ghost, that it is a measurable physical alteration in the body's alarm system, makes navigating those muddy waters just a little bit easier. Thanks for taking this deep dive with us. Keep questioning the wires.